Hello, this is the front desk.
Good morning, everyone, and welcome to another episode of the Crackin podcast with your hosts, Dr. Terry Wyman and Dr. Spencer Barron. How you doing this morning, guys?
Doing good, ready to go,
Lance.
That's great to hear. So today we are joined by Dr. Kathy Dooley. Dr. Dooley is a chiropractor licensed in both New York and Colorado. Dr. Dooley teaches for the Neurokinetic Therapy, Immaculate Dissection, and Somatic Senses seminar series, both based upon human movement optimization. She also teaches gross anatomy for multiple professional institutions, including Albert Einstein College of Medicine, Weill Cornell Medical College, and many, many more. How are you doing this morning, Dr. Dooley?
Good morning. Hello. Thanks for having me today.
It is a pleasure. And I have to give you a little history as to how we found out about you. One of your, I would say like a weekend student or someone that you taught one of your programs to, Dr. Karen Slota, chiropractor, female, one of the only ones in the NFL, Detroit Lions. She made the suggestion. So the first thing I saw about you was Immaculate Dissection.
Yes.
That was a clincher right there. I had to read it 3 times. I go, did I read that right?
Because I'm funny, doctor.
And she spoke so highly of you, and in fact, she can't wait to hear this podcast. So we're going to make it a good one. I brought that up to Dr. Terry, and he thought this was very interesting. We got someone who has taken a chiropractic profession and has, turned it into an educational experience with a deep dive into anatomy and physiology, I would imagine. And so we started listening to a few, other things that you had on YouTube and other channels, and extraordinarily impressed.
Wow, thank you.
Yeah, the fact that you're teaching at 2 medical schools is really cool. That is wonderful.
Multiple. I'm actually teaching at 4 currently.
4.
Yeah. I don't know. I'm still waiting for them to find out that I don't know what I'm talking about. But clearly they think that I must. I'm shocked that they let me work there. Honestly, I'm honored and privileged, and it's like I have to pinch myself every day. It's like a dream come true to be able to work with these incredible students, and the faculty members are out of this world. I just learn something every single day.
Well, what allowed them to rise above prejudice? And I've coined the term professional prejudice. I haven't heard that anywhere, but everybody's slinging the words around about prejudice these days, and yet nobody has really recognized the prejudice that the medical profession has had with chiropractors. So you rise above that, and if you could share what kind of experiences you had in teaching medical people. You ever have any of those?
I'm sorry to interrupt you. Yeah, Dr. Barron, yeah. I'm so shocked that no one's really ever asked me that before. Like, I think people dance around that topic, and you went right for the gutter. I really think that I think I came at this perfect time when education in the medical institutions was starting to get a little bit disparate as far as the amount of anatomy faculty that they had. The amazing, absolutely amazing Dr. Todd Olson, he was the course director at Albert Einstein College of Medicine in New York City, and he was colleagues and very good friends with Dr. Robert Walker, who was the course director at New York Chiropractic College. And they were at an anatomy meeting, and they were chatting, and they said, look, we're not getting any more PhDs in anatomy. We don't know who's going to teach these courses. We need to bring clinicians in and start a master's degree in clinical anatomy and allow for people like chiropractors to be able to get an education that they normally wouldn't get through a master's education. And they chose me. I still don't know why they chose me out of the selection committee. I'm so lucky. I again pinch myself every single day that they chose me, but they did. And coming in to the institution, into Albert Einstein, was really interesting. Dr. Olson has no prejudice. He doesn't have that prejudicial bone in him. He just wants great educators. He just wants to create a great educational team. And he was really, really amazing at it. At that time, the faculty was full of retired surgeons and pathologists and histologists and then myself. And to be able to come into that as a new graduate from chiropractic school. This was 2007.
Wow.
I was like, oh my gosh, I don't know are they going to trust me to educate? And so I was like falling asleep with a 1,500 page 7-point font Grey's Anatomy in my lap every night because I just didn't want to seem like I didn't know what I was talking about. But they took me under their wing, and the thing that was so interesting is that I never experienced an ounce of prejudice there. All they did, because they just weren't going to allow it. Dr. Olson was not going to allow it. And that's the thing, is that if you have professionals that don't allow for prejudicial behavior, it doesn't permeate the culture of the educational institution. And there was just no room for it. It's a progressive university. So yes, I was the first chiropractor on staff that I know about. And I think I'm the first one on the Weill Cornell staff. I believe so. I'm very certain I am on the NYU College of Dentistry staff. And I'm the current only one at Sophie Davis as well. And St. George's, same thing. And why they chose me, not quite sure. But I think it comes down to Dr. Olson creating the environment of a lack of prejudicial bias. And that really makes the difference when you have a leader that doesn't allow for it.
Yes.
They trained me like crazy. They really did take me under their wing. I suffered in the beginning, like everyone suffers when they're learning to become the professional they want to become. And now I look back on that and say, wow, they really did. You could do that with anyone. I'm not particularly special in any regard, I don't think. I think that if we create an environment where people can be educated, they can be educated no matter what. And I've taken that trust they gave me and put it in all the students that I teach, including the continuing education courses.
So let me shift the consciousness in that perspective and say, back when Dr. Terry and I graduated chiropractic college, it was, all the medical, the doctors that were already out in the field practicing were always, there's no research on spinal manual manipulation or anything like that. Show us the research. So now, fast forward it many years later, and I did read actually a research paper that that was published that said that they asked medical students if they would refer to a chiropractor, and they said yes. Those same students that graduated were asked years later, and they said no. And the reason why is because we were never fit into that algorithm of care in the medical education. But now you're in there. So anatomy is very, objective and clinical. Treatment is philosophical in a sense. Well, listen, you can send one patient with high blood pressure to 5 different medical doctors or cardiologists, and you're going to get 5 different types of treatment. So that's when I say philosophical. Do you find yourself educating them in a somewhat chiropractic perspective while you're doing anatomy, while you're teaching?
I try to separate myself a bit to show that I'm a colleague. I'm not just a chiropractor, but I'm their medical colleague. And when I start to talk to them, and of course, when you're medically educated in these institutions, you have to teach anatomy in a clinical way. So I have to know about surgical procedures. I have to know about different pathologies. You end up having to speak about a lot of things, and not just chiropractic as I was educated in. And what happens is that you build a trust with them based upon what you can share with them, what they can get from you. And then they open that door themselves. I don't even have to open it. They start asking me after the lab is over. They'll say, "Hey, Dr. Dooley, can I talk to you about my back?" "Hey, Dr. Dooley, can I talk to you?" And I'm like, "You can talk to me, but I have to refer you to a colleague because I can't treat you. It's a conflict of interest." They're like, "Okay, that's okay." But I can't tell you how many referrals I've given out to them as people
fantastic.
and patients. I think that is where it starts, is the education has to be like, let's build a trust with you, with what you do for a living. Let me show you that chiropractors actually know what medications are. We're trained in pharmacology. We're trained in, venipuncture. We're trained in a lot of the things that you're trained in, pathology, for crying out loud. We know we take a lot of path. So what if I understood all that and also wanted to refer with you? And I think if they are willing to put into their own body, they're going to be willing to refer it to patients. So I do feel like I get to bridge that gap, and they help me do it themselves just by a building of trust.
Do you ever get any antagonism, or not, I shouldn't say antagonism in an aggressive way. Do you ever get any opposition in belief systems, like from students that go, I never really believed in that stuff, And
No, I always expect it,
no?
and I'm ready for
Oh,
it.
that's great.
I actually get that kind of relationship a lot more with my patients than I do people that have been referred to me that have been to chiropractors before, or maybe I have a different style. It's so interesting. If they have a chiropractic bias, it's a tendency towards something they haven't even experienced themselves. They've heard about something. Oh, I had a friend that had this happen to them at a chiropractor's office, and my retort is usually, "Have you also had friends that were misdiagnosed at the medical doctor?"
That's
And
right.
they're like, "Yes." I'm like, "Okay, well, we're not all the same, and mistakes are made. So why don't you see what I can help you with?" I think that I'm still shocked, honestly. One of my first mentors, other than Dr. Olson, was one of the inventors of the hernia stat. He was a general surgeon, and his name was Dr. Ralph Gurr, and he had this place called the Dungeon. He would take me on Saturdays. I was 28 years old, just so green, and just out of chiropractic school, and he would take me down to the basement and show me like the hundreds of articles and inventions that he had made to be able to allow for a laparoscopic surgery of hernia. He did not give a care that I was a chiropractor. All he cared about was that I was fascinated with anatomy. And that's the thing, is that
wow.
See, that's
I think
cool.
the bias comes from us as chiropractors sometimes even encouraging it a bit. And I know that's probably going to get me in a lot of trouble for stating it, but
No.
I expected it and therefore felt the need to defend it, rather than saying, "Oh, why do you feel that way?" and being genuinely curious of why. I asked the good question right back. Why do you not like chiropractors? "Oh, I heard that they crack your neck and then there's this bad sound, or there's this increased stroke risk." I'm like, actually, there's more of a risk of you just stroking out looking up at a building than going to a chiropractor. So, let's actually talk about where the bias comes from, rather than being on the defense, really being genuinely curious of why they think the way that they think. And I think if I have somebody like that in my life ever, which is a lot, we all have that as chiropractors, then I think that the approach of curiosity will always win over the quick defense.
Maybe I'm imagining things, but it seems like higher level education that someone gets, like a neurosurgeon, is going to be more open-minded to what we do as chiropractors versus maybe a lower. You know what? That's stereotyping. I shouldn't even go there.
Depends.
But
It depends on the neurosurgeon, doesn't it?
Yeah, it does, and it's just even versus an orthopedic surgeon, that we call the butchers, whereas the neurosurgeon is the more finesse approach. But regardless, actually, that's not as, now I'm stereotyping. So,
I think it's so easy to do. I think that one of the reasons I love teaching anatomy, well, why I'm obsessed with teaching anatomy, is that it binds all of us. It binds all of us. It binds the patient. It binds the PT. It binds the personal trainer. It binds the massage therapist. It binds the chiropractor. It binds all of us. And anatomy, at the root of it, explains everything. And I think that I always default to that, rather than just identifying as a chiropractor. Of course, I do that. I'm proud to be a chiropractor. I identify as an anatomist because I want everybody to understand their place in understanding how the human body works. And if we had more emphasis on that and less bias of our just general niche, then we could come to a common ground of co-care for that patient and get the best results possible. And that's really what it comes down to, is patient expected outcome and really great results.
So you mentioned something earlier that I thought was a good segue, and that was you spent many a night reading Grey's Anatomy, falling asleep with the book on top of you.
And crying, by the way. I just want to put that out there. If anyone's struggling with anatomy, I was bawling myself to sleep at age 28. I'm 44 now. I'm happy anymore.
I think we all have been in that boat before, holding Grey's Anatomy and crying.
Yeah. Or Guyton Physiology. I remember that one. It was
Yes.
just, yeah.
Uh,
But with that said, Grey's Anatomy featured Fred Netter, the acclaimed artist that had all those drawings, those beautiful depictions of dissection, and it would be a shame if I didn't mention that your artist, that the gentleman that you found that does the artwork, yes,
Danny Quirk. He was the artist, did the artistry for Immaculate Dissection. Yeah.
The guy is amazing.
Yeah, he's incredible.
He's truly amazing. Is there? I don't think I saw, but I think Dr. Terry saw some artwork on someone's body versus on an easel, or is that right?
We used to do that. We don't anymore. Our coursework is not hasn't gone that direction. Just, of course, with 2020, all of us got grounded as far as our world tour of anatomy, and yes, Danny, up until from 2015 to 2020, he did body painting. And even for our webinars, he's done some body painting just to kind of give people with Immaculate Dissection, we're trying to teach anatomy and assessment through an anatomical base, right? Through our clinical auditing process, our flow charts. And so some people have a really hard time visualizing anatomy because the last time they had it was in a textbook or on a cadaver. And so the reason why we're called Immaculate Dissection is because we're trying to make it even more clear for people that, for me, the cadaver doesn't move, but the patient does. I hope the cadaver doesn't move, but the patient doesn't move. I hope the patient does. So for when we went worldwide with our coursework, we were trying to, have Danny paint it as Dr. Folkmore, Dr. Anna Folkmore, genius co-instructor for Immaculate Dissection. Anna and I would teach the anatomy and the assessments and what we call pendulums, these movements that we create to try to create, better motor control training. And then Danny would paint it so that students could see like organ insertion, and it would help them, palpate it once they were on surface anatomy. So yeah, unfortunately we don't do body painting anymore, but up until 2020, it was a really big part of our coursework. Yes, and Danny is great.
Do you think he'll ever bring it back?
If we bring back in-person coursework, which, I do teach still in person with neurokinetic therapy and somatic senses and some of my anatomy angel stuff, possibly. But honestly, it was really labor intensive and really hard to reproduce. And so I'm not so sure that we would do that again. But and our coursework is shifting into something different where our students are really, really interested in the assessment process and becoming very good assessors and good palpators. And while that was helpful and they could still watch the Vimeos and stuff for that, I think that it's not part of our future.
So in medical school, you're helping them palpate?
Oh, sure. We do that all the
anatomy?
time. On the surface anatomy? Yeah, that's a great question, Dr. Byron.
I love that.
The students at Einstein, what they used to do, and we've come away from it as much anymore, which is a shame because of the time constraints, as far as most of the schools are cutting their anatomy hours. They're trying to scale, giving people more clinical hours, and they're cutting back on anatomy. I know, I feel the same way, Doc. I saw the head shake. Dr. Raymond was like, that's not a good idea. I agree. I agree. But that said, let me get back to your question. The palpation, we would have them palpate major landmarks like the ASIS and anterior superior iliac spine, front of the pelvis. We would have them, give a whole surface anatomy exam before they would even do a dissection, which was really, really neat. So yes, that still exists in some of the medical institutions, but it is fading, unfortunately.
That's great.
With your love of dissection, you've talked about that a couple of times. What drove you to actually become a chiropractor and not going to be a medical examiner or even a surgeon?
It didn't even occur to me to do either of those things because I, at age 21, was having panic attacks and didn't realize I had a reverse curve in my neck, reverse lordosis, for the clinicians on the call. And a chiropractor, and a genius chiropractor, she started to talk to me about the autonomic nervous system and how I was activating the sympathetic chain. And she, started to help me with, controlling my neck movements and giving me adjustments. And my panic was largely controlled by that. And I was able to avoid medication, and I became a chiropractor. And that's when I was exposed to anatomy. I didn't have anatomy other than, the anatomy course you have to take as a prerequisite to get into chiropractic school, or the one I took to get in. And then dissection, I'm going to admit to you guys, the first time I dissected, I didn't love it. I was like, I could have done without it. I was like, it's
Wow.
neat, but I could have done without it. And it was when I started tutoring at Logan University. I was a trimester 5 student, and my amazing colleague, Dr. Ross Maddox, told me they needed tutors, and I was broke. To be honest, I was poor, and I was like, I guess I could probably tutor that. I was like, Max, or I said, Ross, I don't know if I can do this. And he's like, oh yes, you can. And he actually encouraged me to do it, and he's one of the big facilitators of my life to I did it. And then I didn't dissect then. I wasn't a prosector. I was just teaching on the cadaver patient, and it wasn't until I started my master's degree that I got decent at it. And then I was like, oh, this could have been another path in my life. And surgeons ask me the same question all the time. I work with surgeons, retired surgeons, and I dissected last semester at Einstein, and the surgeon went to my boss, the course director, Dr. Pincus and Dr. Michal, and he said, "Who dissected this?" I thought I was in trouble, to be honest. I thought I messed something up, and he was like, "This is good. This is what we would expect." But honestly, it doesn't even occur to me to be a surgeon. It never occurred to me to be a surgeon because it is, for me, it would be too limiting personally. I want everyone to learn anatomy. I want everybody. That's why I'm so proud to work for neurokinetic therapy and somatic senses and immaculate dissection. These 3 seminar series don't limit who can take the course. They don't tell a massage therapist they can't take our anatomy course or our human movement courses. No one is disallowed. That to me, I don't like that exclusivity of certain courses where, oh, we don't let acupuncturists take our courses, or we don't like chiropractor. What? That's silly. Like, everyone should be able to get an opportunity. Maybe you could audit it and don't get credit or something, but don't limit people from being able to take your coursework if it's just for educational purposes. And so I feel like anatomy is such a crucial foundational element to being good at any job in human movement that it doesn't make any sense to be limiting.
That's wonderful. I do want to go back though, because you kind of brushed over it kind of fast. In the last 2 years, with I think a lot of it has to do with anatomy, postural, computers, phones, all that kind of stuff. Anxiety has gone through the roof. Can you kind of go back a little bit to talk about your personal anxiety and how anatomy correlates? And there's so many people listening that probably are suffering from anxiety that never think about going to a chiropractor.
Oh man, that's a shame that they don't. And you know what? I didn't either. When I first had panic, I'll never forget it. I was 21. I had been through several motor vehicle accidents, and I have a high energy, like type A kind of personality, but I had never had panic. I had never had what I would consider to be anxiety because I didn't understand what anxiety was. I didn't understand the physiology of anxiety. And I was laying in bed. I remember I was studying organic chemistry, which would make most people be anxious, but it didn't me. I was very good at the topic. And I remember feeling that choking sensation coming on and feeling my heart race and feeling, like I was not, I was losing my consciousness, to be honest. It was very uncomfortable. As most people describe a panic attack, it feels like you're dying. And that's the only way I can really describe it, other than it just did not feel like I was in this realm, this reality. And I remember going to the hospital and them saying to me, well, are you stressed out? I said, no, I had this great boyfriend. I was, studying a topic I really loved. It was, late. I was up studying, but I was excited about my examination. I was excited to be studying, to do better for myself. And he started to give me drugs. He wanted to give me lorazepam, a common anxiolytic, and then he wanted to give me Xanax for a short term. And I said, no, not doing those things. I just made a personal decision to say no. And then I suffered for a month. I suffered with daily panic. I didn't understand what was happening. I was 21 and studying for a master's degree in nutrition at that time. I didn't know what was going on. I was so uneducated. And then this wonderful woman came in. I was working at a GNC, one of those nutritional stores. And this woman came in and she said, are you okay? You don't look like yourself. And I go, actually, I'm having these weird symptoms that they call it panic attacks, but I just feel constantly like my heart is beating constantly, and it just felt very I felt unsafe. And she said, have you ever thought about going to a chiropractor? I said, well, what the heck would a chiropractor do for me? My back doesn't hurt. And she's like, no, they deal with neurology. They deal with the nerves coming out. and the nerves coming out actually connect to some of these chemicals that you're talking about. You're having a chemical reaction, and these chemicals are controlled by nerves. I was like, really? And she's like, yeah. So I started doing the deep dive and reading, and I looked for the chiropractor that had the best rating in my area, and I went to her, and she explained the same thing to me that this woman had said. I was like, wow. Remember, the internet was still new, folks. This is 2000. Okay, it's not like you could, had everything at your feet yet. Internet was still kind of burgeoning, and so I was trying to really dive into understanding the neurology of anxiety. She helped me with that. She let me be one of her assistants. So I got to watch and see how people's symptomatology would calm, how they would have what we know now as a GABAergic response, that a chiropractic adjustment releases gamma aminobutyric acid, GABA, which is an inhibitory neurotransmitter that calms down the anxiety response. So not only does the adjusting calm down norepinephrine and epinephrine, these stress hormones that are encouraging anxiety, they're sedating that. Not that anxiety is bad. I want to completely destigmatize anxiety. It's not like you go to a chiropractor and your anxiety is cured. It's that you go to a chiropractor and it helps with anxiety symptomatology. And that way you can get a better grasp on what your anxiety means to you. And I think that chiropractic is the best physical way without medication to be able to help with the direct control of anxiety, along with exercise, along with diet, along with meditation, all the things I do as well. The chiropractic is part of that for me. And I don't think that people are educated that chiropractic is a GABA experience. It's GABAergic.
Anxiety is so pervasive these days, and I'm sure a lot of our listeners can relate to it. Can you share your thoughts about how you feel an anatomical perspective can help someone with some really, far-reaching conditions like alcoholism or cystic fibrosis and things?
Well, I want to first say that anxiety has a stigma. It's perceived as this psychological experience. And that is generalized anxiety disorder as a DSM-5 category. It's not the same thing. Anxiety is a physiological response that's healthy. Okay? Anxiety gets you out of trouble. If you were to be in a situation where you needed your heart rate up, where you needed to, lift a car off someone, if you needed to run after the bus, if you needed to catch, there's many times I've been close to catching my flight. A little bit of anxiety, creeps up so I can run and catch my flight. Anxiety is neurotransmitters at their finest trying to get you into a situation that's safer than the one that you're in, right? It's when anxiety is pervasive, when anxiety is not able to be controlled by the patient, or when it was like mine when I was laying in bed studying and I had anxiety. That's not an appropriate type of response. So when anxiety is starting to become not helpful for the person and actually starting to promote a harmful perception in the person, that's when anxiety management becomes a very important thing. I think that it's still a very big part of my life. My anxiety gets out of control sometimes, and I have to really think, ooh, what am I'm falling back on my approaches to anxiety. I know my anxiety went up quite a bit in 2020, like probably most people's did, when the world started really changing and there was a lot of perceived threat around us constantly, and even some real threats around us. So anxiety is up because you're trying to adapt and change to the situation and trying to find out what your normal is. So if you don't already go through anxiety management with chiropractic, with exercise, with nutrition, with psychotherapeutics, even in some cases medication, if you're not using those, I highly encourage it. And you don't have to feel like you're a bad person or that you're a sick person because you experience anxiety. But if you don't know how to better control your anxiety, it might affect your life in a way that's deleterious, and it may not feel like a well-lived life.
So based on, and I love the explanation, anxiety, and then, all the sequela to that could be overuse of medications, hallucinogens, alcohol, whatever it might be. Is that how you relate I don't want to, should I say a cure or anatomically speaking, and having things structurally sound and stable, would that help with, other related pathology like alcoholism or cystic fibrosis or things like that.
I see what you're saying. Like when people have certain diagnostic sequelae, like you said, I think that anxiety is never typically its own entity unless someone's actually diagnosed with generalized anxiety disorder or panic disorder. It's part of a sequelae for a lot of people, and self-medication and management can be a part of that. I think that one of the best ways to approach anxiety is to take the emotion out of it. For my patients, I tell them, what does anxiety mean to you? What's it like to you? I'm not a psychologist. I just want to ask them. I'm just generally curious. How does it present? I'm like, oh, I feel a tightness in my chest. I feel like I'm having heart symptoms, or I have perseverating thoughts. I just ruminate, and I can't get past in order to create a present moment. And I tell people, well, anxiety is a chemical cascade of you thinking about the future, you trying to get into a safer situation than you're in right now. Depression is the opposite, right? Not being able to press forward, depressing. And in the present moment is where we think that contentment lies, the absence of anxiety, the absence of depression. And so when it comes to anxiety being present in so many different situations, like you said, it can be present with a lung diagnosis like cystic fibrosis. It can be present with alcoholism or alcohol use disorder. I think that all those things anxiety can be a big part of that. And I think that when we're straight to manage the disorder of the person, the sequelae of the person, anxiety becomes something else that we're looking at to try to help them with, because it's so uncomfortable. It's so uncomfortable unless you're in the direct situation of trying to get out of something that's dangerous. Anxiety doesn't feel uncomfortable when you're in danger. It feels very necessary when you're in danger. But if you're like sitting and trying to focus on your work and you're feeling anxiety, it feels crippling. And I can say that from a personal and professional perspective. I have a weird magnet for anxiety. Like if I'm on an airplane, there's at least 5 times in my career someone's had a panic attack on an airplane. Is there a doctor in the house? Well, I'm a chiropractor without work and having to sit and talk someone off that proverbial ledge while they have panic. I know exactly what it looks like.
So you sit next to my wife when she flies, huh?
Does she get panic attacks?
Oh, she does not like
I don't
flying.
like flying either, by the way. I'm with your wife. I fly a lot. I fly, gosh, what is it, like maybe somewhere between 30 and 50 times a year, depending on, or 50 weekends a year. It's my least favorite thing on the planet to do. And my husband, he's a meditation coach, right? And he talks about how it's my greatest teacher, right? That if I can talk myself off the ledge of turbulence, then I can pretty much do anything. And anxiety is an incredible teacher. I think that there are a lot of techniques for it, and I personally am not gonna pop a pill for it. I feel like I know the chemical consequence of that. The more you take medication for anxiety, the less GABA reception you have, the more downregulation of reception, the more you're going to need to create the same effect. And you still don't have the management tools to get you out of it really for the future. You're just making it harder for your future. I don't believe in robbing for the future to pay for the present. But some of my patients, they manage with anxiolytics, and I'm like, that's totally fine. I want you to have to use those less frequently and not use them on a daily, regular basis. They're very habit forming because they do downregulate reception. They're going to become less effective for you, and that's how you fall into an addiction cycle of medication. So I think that you have to provide people with a lot of management tools, and chiropractic is underutilized for that. I mean, I'm the poster child for it really helping me with my anxiety so much that I became a chiropractor.
Dr. Terry and I have had some extraordinary guests, from Navy SEALs to other military personnel, colonels, and we've had some psychologists and then mental health coaches and things like that. And hearing their stories, especially the military guys or fire department, first responders, and hearing the stress levels. And I hope some of them are listening to this podcast or will listen to it, because chiropractic can help in a perspective the way you were describing. And I think that because they're all getting thrown drug medications over and over again, and some of them have realized it's not working.
it has consequence. It has enormous I'm not saying you can't have it on standby like an inhaler, but just like an asthmatic, you don't tell them to use their
Right.
rescue inhaler 10 times a day. You tell them to use it when they're in rescue. And I totally understand like rescuing somebody with a medication, but I don't think these medications are appropriate for prophylactic purposes. Also don't feel like they're appropriate for consistent use purposes. I mean, the amount of harm that they do, harm reduction means using less of them. Harm reduction is not using chiropractic less. Like the more you use chiropractic, the better it gets. Like that's to me like such an interesting disparity between the physical realm of keeping someone's anatomy on point rather than using medication.
My wife uses a technique when she's flying. Besides gripping my hand and breaking every bone in it, the other technique she uses is breathing.
Oh yes.
And I know you're a really big breathing technique person. And can you tell us some of the your favorite tips and some of your favorite stories of patients that have never really thought about breathing? Because I think we take breathing as an autonomic function in our life. We just open our mouth and air comes in, but it's actually a technique that a lot of people have specialized in. And can you tell us some stories of people that maybe have suffered for 40 years with conditions and all I had to do is teach them how to breathe right and how to calm down?
I have many stories that I love. My own personal story is one of them. Like for me, like I don't manage with medication at all. I personally have just made that decision for myself. No judgment to people who have not, but I feel like when I'm in trouble, that's the first thing I go to. It's interesting how the first thing you go to when you're in trouble with anxiety or panic is you tell someone to take a breath. Just breathe. You go right to it. So, but we don't show someone how to do it because hyperventilation is not a good idea, right? When someone's already anxious, you don't want to do Wim Hof when they're anxious. I think people like need to know what to do. So my husband's a breathing coach, right? Meditation coach. And he would tell you one of the key things that you would do is 5-10s. You would inhale for 5 and exhale for 10. Even Dr. Huberman of Huberman Lab talks about the fact if your exhale is more relaxing, your inhale is more sympathetic, then if you're trying to calm down, you would double your exhale. So if some of the best neuroscientists on the planet are telling you, hey, double your exhale if you want to calm down. If you want to stay in the current state, do a 1-to-1 ratio. Like if you're happy, content, everything's going great, your energy's good, 1-to-1 ratio. And then if you're, trying to train yourself out of, you're trying to train yourself to deal with norepinephrine, then you do more of the hyperventilative type of breathing. But when it comes to if you're in an anxiety state, if you're in, let's say your wife is on the plane, she's very nervous, turbulence is starting, she feels herself getting uncomfortable, then it would be in for 5, out for 10. Trying to make everything as nasal as possible. So that's what I do when I'm on a plane with someone. If they're anxious, I just say, hi, do I have permission to talk to you about this? Do you mind if we just try something together and just, get them focused on a happy scene and get them focused on trying to get in what's called the default, away from the default mode network and into the task positive network. These are cerebral cortical pathways, right? When you're anxious, you're in default mode. You're in the inner nuclei and you're running amok, trying to figure out how to get out of the situation. Or you can switch it laterally to the task positive network, a set of nuclei that allows you to focus on a task. So focusing on a task like breathing is not just you focusing on breathing, not just focus on your physiology of gas exchange. It's getting you into the task positive network. It's getting you to focus on something other than the fact that you're freaking out. And so it's not dissociative, by the way. It's actually a shift of cerebral cortical activation. So I make it very neurological for them. I'm like, let's just take a shift. Let's just shift lateral. Let's just step to the left and to the right of where we are. Let's just widen our stance. I mean, honestly, if you wanted to increase your balance, you don't go narrow, you go wide in your stance. So why wouldn't you do the same things cerebrally, right? So I just have them inhale for 5, exhale for 10, inhale for 5, exhale for 10. And then my husband, of course, he developed our Anatomy Angel Respiration Meditation series. And so when someone asks me, how do I meditate? I'm like, well, he was trained by Buddhist monks and they pretty much live their entire life around meditation. So he was like, why don't you just start with in for 5, out for 10? Try that for 5 minutes and see if you feel different afterwards. And everyone does. You feel immediately different. And I've had patients that have had years of anxiety, years of gastroesophageal reflux disease, where their PPIs are now becoming dangerous for them because they're not managing their stress. They're down-regulating their own bicarbonate production. So the normal acid they produce becomes harmful to their stomach. So I teach them how to do some of this breathing training, teach them some of the ID breathing. And they are like, wow, I don't know why that helps me digest my food better, but it does. I'm like, well, because you're now not as sensitive to the normal acid you produce. That's the thing, is that stress is a killer. Anxiety is a killer if it's not controlled. But it's your friend if you allow it to be. You just have to learn how to be the CEO of your breathing. You have to be the CEO of your stress management.
In for 5, out for 10.
Mm-hmm.
Explain.
Yeah, so when you inhale for a 5-second count, especially through the nose, you're going to activate vasodilators that are in your nose nitric oxide receptors. And that's going to allow you to open up blood vessels, decrease vasoconstriction a bit so that you can get blood to all your variety of parts, right? And then as you exhale for 10, the exhalation process is going to do a lot of vagal nerve stimulation, right? And so that's going to sedate the heart rate, it's going to sedate the breathing rate, and then you're blowing out CO2. So, of course, you're now delivering oxygen. You don't deliver oxygen when you inhale, you deliver oxygen when you exhale. So if someone needs more oxygen, you're going to promote their exhalation, right? So the inhalation, so it's very anatomical and it's just biomechanical, but also it's very simple. You just have them in for 5, out for 10. Try to avoid the mouth for inhalation because the tongue will go backwards, start to occlude the airway with the epiglottis, and then the person might release too much norepinephrine, and then of course then you're in stress zone again. So that's why you want all the inhales to be through the nose so you can activate those vasodilators, the nitric oxide receptors, but also take the tongue away from the larynx. We don't really want to close off your airway during inhalation.
Love it. Dr. Terry had a dentist on as a guest. I'm sorry, what was his name, Terry?
Dr. Kacker, Dave Kacker.
And he made a big deal about nasal breathing versus mouth breathing, and talked about nighttime, put a little strip of tape over your mouth and all that. And Dr. Dooley, within like a couple of weeks, all of a sudden I see an article on one of the media, one of the mainstream media,
New York
about
Times, actually,
how crazy it is to
yes.
Now these kids are putting tape over their mouth at night and everything.
Yeah. It's crazy. It's crazy to me that people think that that's crazy. Like I've been mouth taping. My husband and I mouth tape every single night. I have a history of 3 sleep disorders from childhood: sleep apnea, parasomnolence, sleep talking, sleepwalking, the deal. And I had such trouble sleeping. And you put a piece of tape on my mouth, and I put a breathe right strip across my nose, just so psychologically I know I'm getting a little bit more air in my nares. Put a piece of tape across. Yeah. I put it across the mouth. I know Boteco likes to put it up and down. I put it across because I can't be trusted not to talk in my sleep. And it's the best night's sleep I ever had in my life. And I noticed that my pulse ox, and if you're thinking it's so dangerous, then check someone's pulse ox with and without it, and actually see if it's actually dropping their O2 levels, if you're really worried about it. But I think all of that is just a bunch of people poo-pooing something that doesn't have enough peer review for them to support the idea yet. And I'm just like, why can't people just be curious? Why do they have to jump to being so judgmental right out of the gate? Like, it's, I think that the dentist is right. The majority of people that mouth breathe, they end up with the crowding of the teeth. We have these kids with these stuffy sinuses, probably because their diets are full of processed foods. They're not eating foods that are allowing them to chew. They get all this congestion in their nose, and so they start mouth breathing. And during their tooth development, that's a very big problem. They start to mouth breathe and crowd the teeth, decrease the palatal width, take the tongue backwards, create more norepinephrine, and there you go. I mean, I grew up in a house of a bunch of smokers. I didn't have a shot at being able to breathe properly. And so my whole life has been trying to fight to be able to breathe properly. And if a piece of tape across your mouth helps you to do it, helps you to increase the quality of your sleep, then I think it's not something to jump to poo-pooing, but maybe something to jump to trying.
Well, I'll tell you that you're going to need right now to do a little bit of nose breathing, because we have our special feature right now, our rapid fire, 5 questions.
Okay.
Rapid fire. and your answers really count big.
Okay.
You ready?
Got my nasal breath.
Okay.
Got it.
Here we go, Dr. Dooley. What is your favorite mattress and pillow?
The favorite mattress is the one that you don't sink into. If you watch the Adam Ruins Everything on mattresses, you'll find that the majority of them are the same.
Pillow?
Again, I'm something that keeps your nose in line with your sternum.
Ooh, I like it. All right, very good. What essential exercises that everyone can benefit from that you could suggest that they could start right now?
Breathing training and the get up.
The get up.
Mm-hmm.
Ooh, is that with a kettlebell?
You don't have to.
Or wait, I don't.
Nope, you don't have to. I am a kettlebell advocate, but you don't have to.
Yes.
No, you can use your own body weight. In 2020? 2021, I did 66,000 get-ups that year. I did one get-up for the day of the year that it was. So at day 365, I did 365 get-ups, and this year it's the lunge. Last year was the push-up. 2021 was the get-up, and it will help you to share movement across multiple joints and learn how to not overuse your shoulder, not overuse your neck, spine, hips. That's the best exercise on the planet if I had to pick one. Along with breathing training.
Yes. Do you have video of the get up? I know you
So
have videos out there.
So many. Email me, folks. I'm happy to send you my get up videos.
Which is the check get up, where they start you in a supine position into supine 90-90. Then you move to a 4-month position where you adduct a little bit more. You go into sideline 5-month position, then go into 7-month prop. And then the rest of it looks pretty similar to the rest of the get up, only they'll do a drag forward for centration and then come up to.
Dr. Terry, you got to make sure our engineer, the lovely Lance, includes some links to Dr. Dooley's videos on that.
Absolutely.
All right. Question number 3. What favorite muscle?
Oh, you're making me play favorites. Oh, that's so mean.
A body part, favorite muscle. What would one that you maybe like talking about most or educating most in your classroom setting?
Well, I would say in the past it was the diaphragm, the thoracic diaphragm, but these days I would say the 7 anatomic diaphragms, learning how they all relate to each other. So can I say the 7 diaphragms or no? Do I have to pick one?
Wait, the what? Say it again.
Mm-hmm,
the
7.
which one?
Mm-hmm.
The 7, like.
Oh, are
5,
you
6,
ready?
7?
Are you ready to get your mind blown by something you already know? So
please, because now I'm breaking the rule here. It's not rapid fire all of a sudden. Go ahead.
Okay.
I'm dying to hear this.
I can handle the rapid fire if you want to add an extra question. So you know how they talk about the 7 chakras, right? That's been around for thousands of years. Well, there's 7 anatomic diaphragms. I thought to myself, why do they say 7 chakras? Why do all of these backgrounds, they always talk about these 7 things needing to be lined up? And then I started to really look into grays and why 7? Why are these? What's a diaphragm? A diaphragm septates things between different function, right? And it has to be in midline. So I'm like, okay, there is a diaphragm between the hypothalamus and the pituitary. The owner and the coach of your NFL team, right? They're sending out all the hormones. There's a there's a diaphragm between your nasopharynx and your oropharynx that prevents, that's the air going in and out and food preventing it from going out. That's the soft palate. There's a floor of the mouth diaphragm, right? That one separates the mouth from the neck. Then there's the superior thoracic aperture diaphragm that separates the neck from the thorax. Then the thoracic diaphragm separates the thorax from the abdomen. Then there's a pelvic floor diaphragm that separates the abdomen from the perineum, and then there's the perineum that separates, that from the outside world. So there are 7 diaphragms. They're anatomical. So my favorite thing to talk about is the 7 diaphragms. But if I had to pick one of them, I'm assuming that I probably would pick the thoracic diaphragm because people need to talk more about breathing and how much it affects the viscera. But lately, I want people to understand that there are 7 of those, and they do line up with the chakras. And I want people to understand their scientific basis to that. What seems to be metaphysical, that stuff's not metaphysical. That stuff is on point.
Oh, that is beautiful. Okay, back to rapid fire.
Okay, sorry.
Gosh. I think this is number 4. Yes,
Okay.
favorite. Your favorite go-to supplement, nutritionally speaking.
That's so tough. It really depends on the person in front of me. One that I think that more people could benefit from that don't is sunlight. I think that I don't stand alone in that regard. I think that people are shoving vitamin D3, K2 down their throat and not getting sun activation of it. So probably that would be my favorite.
Very good. Vitamin sunlight. Very good. I like that.
My second favorite is niacin.
Okay.
Yeah.
Why?
Nicotinic acid.
Where did that come from?
I think that we are dealing with a big crisis of heart disease. Heart disease is definitely a comorbidity of COVID, and we're in the middle of the COVID pandemic right now. And I think that we don't talk enough about hypertension and the control of blood pressure, and niacin being an HDL donor. We all know how great HDL is. So I think that people, it's uncomfortable supplement, but it's a vasodilator, kind of like breathing through your nose is. So.
Dr. Terry, can we get Dr. Dooley on again? Because I'm trying to curb my branching because there's so much that she could share. Yeah. Okay. How about number 5?
Rapid fire. Sorry, rapid fire.
Last thing. It's my fault.
Poor Spencer.
Most people would tell you I'm really good at rapid fire, and they have to tell me to slow down. So.
And Spencer's not.
It's all a front. It's rapid fire, and then I get in this quagmire of branching into other questions because you raised such an index of curiosity. All right, number 5 and last.
Yes.
Favorite outdoor activity or sport that makes you feel like a kid?
Oh, skipping.
Love that.
It's so underused.
I told a patient. I told a patient the other day she was having a bad day. I go out and skip, and she looked at me like I was crazy. I go, when's the last time you danced in your room and went out skipping down the? She goes, oh, well. I go, she's all, I can't do that. I go, are you afraid of what people are going to think? I go, have you ever looked at somebody skipping and been mad? I go, you will make everybody else happy around you.
Hilarious.
So
not to mention seeing an adult
answer.
skip, people are always like, what the heck are they doing? And then they have to think to themselves.
But
they do.
Smiling.
They're like, oh, that person is having a good time.
Yeah.
And I think that skipping is used by a lot of Olympic teams for their sprinters. It helps them. Yeah,
they are.
It's something that's underutilized when someone's transitioning from walking into sprinting or running again. I get my patients that they get hurt sprinting. They walking's not challenging enough, and I have them skip, and they're like, wow, I didn't realize how much fun that was going to be and how great it made me feel and how hard it was.
I love it.
I love that. I give a shout out. I don't know him, so I'm going to put that right out in front, but I'm going to give a shout out to Kevin Hart because for a while, every Friday, he would put a video out and call it Crazy Dance Day. And all he would do is put music on and just start dancing and moving. And you'd see him skipping and moving. You cannot watch it without smiling. And so I started telling all patients that are having a bad day to go out and skip for 5 minutes and put on their favorite song and just let their body flow. And I go, you can't worry about how people are going to feel because I guarantee everybody looking at you is going to smile.
That's it. I'm adding that to my daily program again. You convinced me, Dr. Raymond. I'm doing it. Yeah,
that's awesome.
Great.
That's awesome.
So we are close to wrapping up, but man, we have more questions. I'm sure Dr. Terry does. We have to get her back. I'm telling you, we have to get her back.
Okay, I'm happy to come back.
That's one, but I do want to end with something that's very relatable to our listeners, and that is just simply the question about your thoughts on kneeling, your thoughts on standing desks, therapy ball chairs. This is stuff that people have to deal with every day. Just unload.
I think that people are way too rigid with sitting. I think sitting can actually be okay as long as you don't do it too long. And I saw a Stu McGill seminar back in 2013. What a great professional. He said the best position you're in is one you're not in longer than 15 minutes. And
Ooh,
I
I love
thought
that.
that was a game changer. And I tell that to patients, like, just set a timer for 15. And if you're seated, stand up. If you're standing, sit. I'm a big proponent of kneeling. I don't use a chair in my office. My patients see me, I'm in kneeling because it provides femoral centration, a lot of strength. It's the bottom part of a lunge. It's a phase of the get up. And I want them to see that I'm working really hard on my femoral movement. And I don't want a hip replacement. I've been warned that I am destined to have one in my older age by orthopedists. I'm like, well, maybe you were given a crystal ball that I wasn't given on graduation, but I'm not doing that if I don't have to. And let's see how much control I actually have in my own health situation. And I think that, don't be too hard on yourself, but be consistent with yourself to make changes of let's use a kneeling chair, then let's switch to a seated position. Now let's put our feet up. Now let's put our feet down. Let's stand up. Let's stagger our stance. Let's go wide with our stance. Let's go narrow with our stance. Like, try different things. Try to be a little bit more, I don't know, just try different positions.
When you say kneeling, do you mean on both knees or in a lunge or like take a knee or what?
Yeah, I'm happy to send you folks my video on YouTube. It's kneeling while working, and I just put into half kneeling.
Oh,
I put one leg forward, one knee down. You could use an RX pad. I just use like a mat or whatever. I've gotten adjusted to it over time. And some of my patients are like, my knee hurts after a while. I'm like, well, you're not adapted to it yet. Let's use a yoga block, or you'll see me in the video use, different, things to help support you. And what happens is you build a lot of strength in that position. There's not a lot of positions that build strength in a consistent seated position, but that's one that does.
That is so good. I love it. Well, we're going to wrap up on that, and this is not the last time we hear from you, whether in this forum or I am definitely going to get you in to some of our programs, our sports medicine programs. Dr. Terry, Pro Sport, and myself with the Professional Football Chiropractic Society. I think you'd be sensational. You're definitely, as much as people know about you, I think you need to be unearthed and brought out to the open to really share the knowledge. It's so pleasant to hear.
I am so happy to help in any way. I'm addicted to this stuff just as you folks are, so I'm happy to help in any way I can. Thank you for having me on.
Well, this is our platform of reaching a lot of people to help people, expose them to different thoughts and different people around the world. So you are definitely on my list. We will bring you back for part 2. And we really appreciate your time because this was fantastic.
I really appreciate you. Thank you for what you do for our amazing profession and the education of the world, really. I love being a part of it. Thank you so much for having me on.
Thanks, Dr. Dooley. Thank you.
Thank you for listening to today's episode of the Crackin podcast. We hope you enjoyed, and make sure you follow our Instagram at Crackin Podcast. Catch new episodes every Monday. See you next time.